Hi everyone, welcome to our module on arthritis and spondyloarthropathies. In this video, we'll discuss arthritis and spondyloarthropathies, which are extremely important topics for both USMLE Step 1 and NEET PG. Before diving into the video, I would like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for all the students. If you find it useful and wish to support its development or help us improve the quality of the videos, voluntary contributions are welcome. The link is in the description and is also on the screen. You can pay with any of those payment methods that are mentioned. Arthritis simply refers to inflammation or degeneration of joints. For exam purposes, arthritis is usually divided into several major categories. The first category is degenerative arthritis, which includes osteoarthritis. The second category is autoimmune arthritis, which is primarily represented by rheumatoid arthritis. The third category includes crystal-induced arthritis, such as gout or pseudo-gout. The fourth category, seronegative spondyloarthropathies, which includes Ankylosing Spondylitis, Psoriatic Arthritis, Reactive Arthritis, and Enteropathic Arthritis. When solving exam questions, your main goal is to recognize the disease based on the clinical pattern described in the question. In exam questions, arthritis is rarely asked directly by name. Instead, the question will give several clues. These includes clues often includes the age of the patient, which joints are involved, whether the joint involvement is symmetric or asymmetric, and whether there are systemic symptoms such as fatigue or fever. The question may also include laboratory findings or joint aspiration results. One very important distinction is between inflammatory arthritis and degenerative arthritis. Inflammatory arthritis typically causes morning stiffness lasting more than an hour, whereas degenerative arthritis causes stiffness that improves quickly with movement. Recognizing this difference is extremely useful when approaching exam questions. Osteoarthritis is the most common form of arthritis worldwide. The primary problem in osteoarthritis is degeneration of the articular cartilage. As the cartilage gradually breaks down, the underlying cartilage becomes exposed. This leads to several secondary changes, including subchondral bone remodeling, formation of osteophytes, and narrowing of joint spaces. The joints most commonly affected are the hips, knees, spine, and distal interphalangeal joints of the fingers. Patients with osteoarthritis usually present with joint pain that worsens with activity and improves with rest. Morning stiffness is usually short, typically less than 30 minutes. Another common symptom is crepitus, which is a cracking or grinding sound during joint movement. On physical examination, patients may develop Haberden nodes, which occur at the distal interphalangeal joints. They may also develop Bouchard nodes, which occur at the proximal interphalangeal joints. Radiographic imaging often shows joint space narrowing, osteophytes, and subchondral sclerosis. The underlying cause of osteoarthritis involves progressive breakdown of articular cartilage. This breakdown can occur due to mechanical stress, aging cartilage, or dysfunction of chondrocytes, which are the cells that are responsible for maintaining the cartilage. As cartilage deteriorates, the cushioning between the bones is lost. This causes the bone surfaces to rub against each other, which leads to inflammation and pain. Over time, the bone responds by remodeling itself and forming osteophytes, also known as bone spurs. Rheumatoid arthritis is a chronic autoimmune inflammatory disease that primarily affects the joints. One of its defining characteristics is symmetric involvement of joints. The disease usually begins by affecting the small joints first, particularly the metacarpophalangeal joint, the proximal interphalangeal joints, and the wrist joint. Importantly, rheumatoid arthritis usually spares the distal interphalangeal joints. It spares the distal interphalangeal joints. Without treatment, rheumatoid arthritis leads to progressive destruction of the joints and the deformities. The pathogenesis of rheumatoid arthritis begins with autoimmune activation of the synovial membrane. Several immune cells are involved in the process involving CD4 positive T cells, B cells, and macrophages. These immune cells release inflammatory cytokines such as tumor necrosis factor alpha, interleukin 1, interleukin 6. These cytokines stimulate synovial proliferation and chronic inflammation, leading to joint damage. One of the hallmarks of rheumatoid arthritis is pannus formation. Pannus is a thick layer of inflamed synovial tissue that grows over the articular cartilage and the bone surface. This tissue contains inflammatory cells, fibroblasts, and new blood vessels. As the pannus expands, it gradually destroys the cartilage and erodes the bone, which leads to deformities and loss of joint function. I don't know why. It may just have been missing, but I'm sorry for that. Patients with rheumatoid arthritis commonly experience morning stiffness lasting longer than an hour. They also develop symmetric swelling of small joints, particularly in the hands and wrists. As the disease progresses, characteristic deformities can develop. Examples include ulnar deviation of the fingers, characteristic deformity called as the swan neck deformity of the digits, and Boutner deformity. This is called as this is how the Boughton deformity looks like, and this is swan neck deformity of the fingers. Rheumatoid arthritis may also produce extra-articular manifestations affecting other organs. Several laboratory tests help support the diagnosis of rheumatoid arthritis. One commonly detected antibody is rheumatoid factor, which is autoantibody that is directed against the Fc portion of IgG. Another important antibody is anti-cyclic citrullinated peptide antibodies, often called anti-CCP antibodies. The anti-CCP antibodies are highly specific for rheumatoid arthritis. Inflammatory markers such as ESR and CRP are usually elevated. Joint aspiration reveals inflammatory synovial fluid with increased leukocytes. Rheumatoid arthritis is not limited to joints. It is usually a systemic autoimmune disease. Patients may develop several extra-articular manifestations. These include rheumatoid nodules, interstitial lung disease, vasculitis, anemia of chronic disease, and osteoporosis. Severe disease often has multiple systemic complications. Patients with severe rheumatoid arthritis often have multiple systemic complications. Rheumatoid nodules are firm, painless nodules that develop under the skin. They are most commonly found on the extensor surfaces of the elbows and forearms. Microscopically, these nodules contain central fibrinoid necrosis, which is surrounded by inflammatory cells. They're often associated with high levels of rheumatoid factor. Felty syndrome is a complication of long-standing rheumatoid arthritis. It is defined by a classic triad of which is consisting of rheumatoid arthritis, splenomegaly, and neutropenia. Because neutrophil counts are low, patients with Felty syndrome have increased susceptibility to infections. Imaging plays an important role in monitoring rheumatoid arthritis. Typical radiographic findings include joint space narrowing, marginal bone erosions, and periarticular osteopenia. In advanced disease, imaging may reveal joint deformities, subluxation, and ankylosis. These changes occur due to characteristic inflammation and pannus formation. It is very helpful to compare osteoarthritis and rheumatoid arthritis. Osteoarthritis is a degenerative disease, whereas rheumatoid arthritis is an autoimmune inflammatory disease. Osteoarthritis often affects the distal interphalangeal joints, while rheumatoid arthritis usually spares these distal interphalangeal joints. Osteoarthritis tends to be asymmetric, while rheumatoid arthritis is typically symmetric. Morning stiffness in osteoarthritis is short, while in rheumatoid arthritis, it usually lasts for more than an hour. Now we move on to the seronegative spondyloarthropathies. This group includes several inflammatory conditions that share a number of important characteristics. The term seronegative means that these disorders typically test negative for rheumatoid factor. Another important feature is a strong association with HLA-B27. These conditions commonly involve the spine and sacroiliac joints and they frequently cause enthesitis, which means inflammation to the sites with tendons or ligaments attached to the bone. The major diseases included in this group are ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and enteropathic arthritis. Recognizing these shared features helps quickly identify these disorders in all the exam questions. Ankylosing spondylitis is a chronic inflammatory arthritis that primarily affects the spine and sacroiliac joints. It usually affects young males, often beginning in late adolescence or early adulthood. One of the key symptoms is chronic inflammatory back pain. Unlike mechanical back pain, the pain of ankylosing spondylitis improves with physical activity and it worsens with rest. This pain worsens with rest. Rest. Another important association is HLA-B27 positivity, which is commonly present in the affected patients. Over time, inflammation leads to fusion of the vertebrae, reducing spinal flexibility. In ankylosing spondylitis, inflammation usually begins in the sacroiliac joints. From there, the inflammatory process spreads to involved vertebral bodies, spinal ligaments, and intervertebral discs. As the disease progresses, new bone begins to form between the adjacent vertebrae. This abnormal bone formation eventually causes fusion of the vertebral bodies, which reduces spinal mobility. One of the most characteristic radiographic findings in ankylosing spondylitis is the bamboo spine appearance. This occurs because of syndesmophytes, which are bony ridges that form between the adjacent vertebrae. As more syndesmophytes develop, the vertebrae becomes fused together, giving the spine a rigid appearance resembling a bamboo stalk. The result is progressive loss of spinal flexibility and stiffness. Patients with ankylosing spondylitis commonly experience chronic lower back pain and stiffness, especially in the morning. Spinal mobility gradually becomes reduced over time. In addition to joint symptoms, several extraarticular manifestations may also occur. These include uveitis, inflammation of the aorta known as aortitis, and restricted lung disease caused by reduced chest wall expansion. A classic exam clue is a young patient with chronic back pain that improves with activity. Psoriatic arthritis is an inflammatory arthritis that is associated with psoriasis. Like other spondyloarthropathies, it is typically seronegative, meaning the rheumatoid factor is absent. Some patients also show HLA-B27 association. A distinguishing feature is the involvement of the distal interphalangeal joints, which is different from rheumatoid arthritis, where these joints are usually spared. Patients with psoriatic arthritis often present with joint pain, swelling, and stiffness. A classic sign is nail pitting, which reflects the involvement of the nail matrix. Another characteristic feature is dactylitis, which refers to diffuse swelling of an entire finger or two. This gives the appearance of sausage digits. The disease may involve peripheral joints, the spine, and the sacroiliac joints. Reactive arthritis is an inflammatory arthritis that develops after certain infections. It's most commonly triggered by infections caused by Chlamydia trachomatis, Salmonella, Shigella, Campylobacter. Like other conditions in this group, reactive arthritis is associated with HLA-B27. The arthritis occurs after the infection, even though the joint itself is not directly infected. Reactive arthritis is often remembered using the mnemonic can't see, can't pee, can't climb a tree. This phrase represents the classic triad of symptoms. Conjunctivitis affects the eyes, urethritis affects the urinary tract, arthritis affects the joints. Joint involvement is typically asymmetric and often affects the lower limbs. Two important findings commonly seen in seronegative spondyloarthropathies are dactylitis and enthesitis. Dactylitis refers to diffuse swelling of an entire finger or toe, producing the characteristic sausage digit. Enthesitis refers to inflammation at the insertion site of the tendons or ligaments. Common locations includes the Achilles tendon and the plantar fascia. These features help distinguish these disorders from rheumatoid arthritis. Enteropathic arthritis occurs in association with inflammatory bowel disease, particularly Crohn's disease and ulcerative colitis. Patients may experience peripheral arthritis, sacroiliitis, and spinal inflammation. Joint symptoms often worsen during flares of intestinal inflammation. So, recognizing the link between gastrointestinal disease and joint symptoms is an important exam clue in those cases with enteropathic arthritis. All seronegative spondyloarthropathies share several characteristic findings. They're typically negative for rheumatoid factor that they are commonly associated with HLA-B27. They frequently involve the inflammation of spine and sacroiliac joints. They often produce enthesitis and asymmetric arthritis. The major diseases included in this group are ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and enteropathic arthritis. Synovial fluid analysis is an important diagnostic tool when evaluating arthritis. Several features of the fluid are examined. These includes the appearance of the fluid, the white blood cell count, the presence of crystals, and whether bacteria are present. These findings help distinguish between degenerative arthritis, inflammatory arthritis, or whether an infection or any crystal-induced arthritis. Different types of arthritis produce different patterns in synovial fluid. Non-inflammatory conditions such as osteoarthritis typically show white blood cell counts below 2000. Inflammatory conditions such as rheumatoid arthritis show white blood cell counts between 2000 and 50,000. Septic arthritis often produces very high white blood cell counts above 50,000, whereas crystal-induced arthritis such as gout may show variable counts with identifiable crystals. So, when approaching an arthritis question, a systematic method is helpful. First, determine how many joints are involved. First, how many joints are involved? Second, determine whether the involvement is symmetric or asymmetric. Third, evaluate whether there are systemic symptoms such as fever or fatigue. Fourth, examine laboratory findings. And finally, analyze the synovial fluid if available. This structured approach helps narrow the diagnosis effectively. So, whenever a patient presents to you with suspected arthritis, first ask the patient how many joints are involved. How many at how many at level of how many joints do you have the pain? After that, the next question is whether both the joints on both the sides are involved. So if patient says that they have been experiencing right knee pain, also ask if there's any possibility or any presence of symmetry, if there's left knee pain or not. After that, assess systemic symptoms like any recent fevers or infections, and then we can do or perform a laboratory testing and analyze synovial fluid if it's available. Degenerative arthritis, such as osteoarthritis, results from mechanical damage to the joints. Pain usually worsens with activity, and morning stiffness is short. Inflammatory arthritis results from immune-mediated inflammation. Morning stiffness usually lasts more than an hour, and joints may appear swollen and warm. Systemic symptoms may also occur. When small joints are affected, the pattern of joint involvement provides important clues. Rheumatoid arthritis typically causes symmetric involvement of metacarpophalangeal joints and proximal interphalangeal joints. Psoriatic arthritis commonly involves distal interphalangeal joints along with nail pitting and dactylitis. A helpful exam tip is the DIP involvement usually suggests psoriatic arthritis or osteoarthritis, not rheumatoid arthritis. Mechanical back pain typically worsens with activity and improves with rest. Inflammatory back pain behaves differently. It is usually worse in the morning and improves with exercise. Ankylosing spondylitis is the classic example of inflammatory back pain. Exam questions often describe a young patient with back pain that improves with activity. Now, coming to crystal-induced arthritis. Crystal-induced arthritis includes gout and pseudogout. Gout is caused by monosodium urate crystals which appear needle-shaped and negatively birefringent under polarized light, whereas pseudogout is caused by calcium pyrophosphate crystals which are rhomboid-shaped and positively birefringent. These crystal patterns are frequently tested in all the kinds of exams. Let us review several high-yield diagnostic associations. DIP involvement suggests osteoarthritis or psoriatic arthritis. Symmetric small joint arthritis suggests rheumatoid arthritis. Young male who presents with inflammatory back pain suggests ankylosing spondylitis. Arthritis following infection suggests reactive arthritis. Arthritis occurring with inflammatory bowel disease suggests enteropathic arthritis. Recognizing these patterns allows rapid diagnosis during exams. Now, we will briefly discuss the treatment principles for inflammatory arthritis, which are also tested in integrated clinical questions. The main goals of treatment are to reduce inflammation, relieve pain, prevent joint damage, and preserve joint function. Early treatment helps prevent irreversible joint destruction. So several drug classes are used in treatment. These includes NSAIDs, corticosteroids, disease-modifying anti-rheumatic drugs or DMARDs, and biological agents. One important concept to remember is that early treatment is critical because it helps prevent irreversible joint destruction and long-term disability. Methotrexate is considered the first-line disease-modifying drug for rheumatoid arthritis. Its mechanism involves inhibition of dihydrofolate reductase, which ultimately reduces the proliferation of immune cells. By suppressing immune activity, methotrexate helps decrease inflammation and slow the progress of joint damage. However, methotrexate can produce several adverse effects. These include hepatotoxicity, bone marrow suppression, and pulmonary toxicity. For these reasons, patients receiving methotrexate must be carefully monitored with laboratory testing because they can present with hepatotoxicity, bone marrow suppression, and pulmonary toxicity. In addition to methotrexate, several other disease-modifying anti-rheumatic drugs may be used in rheumatoid arthritis. One example is leflunomide, which works by inhibiting pyrimidine synthesis, thereby reducing lymphocyte proliferation. Uh, Another medication is sulfasalazine, which has anti-inflammatory effects. A third example is hydroxychloroquine, which acts as an immunomodulatory agent. These medications help slow disease progression and reduce inflammatory activity in rheumatoid arthritis. Biologic therapies are never are biological therapies are newer medications that are used to and are designed to target specific inflammatory cytokines. One important group of biological agents consists of TNF inhibitors. Examples include infliximab, adalimumab, and etanercept. These medications work by blocking the activity of TNF alpha, which is a major driver of inflammation in rheumatoid arthritis. By blocking TNF alpha, these drugs significantly reduce inflammation and joint damage. They are typically used in moderate to severe disease that does not respond adequately to traditional DMARD therapy. Management of inflammatory arthritis usually follows a stepwise approach. Initially, NSAIDs may be uh, used to relieve symptoms such as pain and stiffness. Next, disease-modifying drugs such as methotrexate are initiated to slow disease progression. If the disease remains active despite these medications, biological agents may be added. Early and aggressive treatment helps prevent joint deformities and long-term functional disability. Radiographic imaging provides important clues for diagnosing osteoarthritis. Typical findings include joint space narrowing, which occurs because the cartilage is lost. Another feature is osteophyte formation, which refers to bony outgrowths of the edges of joints. Additional findings include subchondral sclerosis, reflecting remodeling of bone beneath the cartilage. These changes most commonly occur in the knees, hips, spine, and distal interphalangeal joints. The radiographic findings in rheumatoid arthritis differ from those in osteoarthritis. In rheumatoid arthritis, imaging typically shows symmetric joint space narrowing and marginal bone erosions. Another finding is periarticular osteopenia, which occurs because inflammation leads to bone loss around the joints. So, as the disease progresses, radiographs may show joint deformities, subluxation, and eventually ankylosis. These changes are caused by chronic synovial inflammation and pannus formation. Imaging is also important in diagnosing ankylosing spondylitis. Early in the disease, imaging may show sacroiliitis, which is inflammation of the sacroiliac joints. Later in the disease, patients develop syndesmophytes, which are bony bridges that form between the adjacent vertebrae. Eventually, these bridges cause fusion of the vertebral bodies, producing the characteristic appearance known as bamboo spine. This occurs because of ossification of spinal ligaments and chronic inflammation. It is extremely helpful to compare the major types of arthritis. Osteoarthritis is a degenerative disease which is characterized by bone loss and cartilage loss, and it often involves the distal interphalangeal joints, whereas rheumatoid arthritis is an autoimmune inflammatory disease that usually affects the symmetric small joints. Ankylosing spondylitis primarily affects the spine and sacroiliac joints. Psoriatic arthritis often shows distal interphalangeal joint involvement along with psoriasis. Reactive arthritis occurs after infection and usually affects lower limb joints. Recognizing these patterns is critical for solving exam questions quickly. So, when approaching an arthritis question in an exam, it is useful to follow structured strategy always. So, first, identify the age of the patient. Second, determine how the joints are involved. Third, evaluate whether the joint involvement is symmetric or asymmetric. Fourth, look for systemic features such as fever, fatigue, skin findings, or gastrointestinal disease. Finally, interpret laboratory tests and imaging findings. Using this systemic approach helps narrow the diagnosis efficiently. Several inflammatory arthritis are associated with HLA-B27 genetic marker. These include ankylosing spondylitis, psoriatic arthritis, reactive arthritis, enteropathic arthritis. These diseases share several features. They are typically seronegative for rheumatoid arthritis. They often involve the spine and sacroiliac joints, and they frequently cause enthesitis, which is inflammation where the tendons attach the bone. Recognizing this shared pattern helps identify these disorders during exams. Joint distribution provides patterns that are valuable diagnostic clues. So, if the distal interphalangeal joints are involved, the likely diagnosis includes osteoarthritis or psoriatic arthritis. If the metacarpophalangeal and proximal interphalangeal joints are involved, think about rheumatoid arthritis. If the spine and sacroiliac joints are involved, consider ankylosing spondylitis. If arthritis occurs asymmetrically in the lower limbs, reactive arthritis is a possibility. Several clinical clues appear repeatedly in exam questions. Morning stiffness which is lasting more than an hour, suggests inflammatory arthritis. Joint pain that worsens with activity suggests osteoarthritis. Young patient with inflammatory back pain suggests ankylosing spondylitis. Arthritis occurring after infection suggests reactive arthritis, and arthritis with psoriasis suggests psoriatic arthritis. Recognizing these clues makes diagnosing easier. Different arthritic diseases produce different complications. Rheumatoid arthritis may lead to joint deformities, rheumatoid nodules, and vasculitis, whereas ankylosing spondylitis produce reduced spinal mobility, or restrictive lung disease, and uveitis. Early diagnosis and treatment are important to prevent long-term disability and complications. Let us summarize the most important concepts from this lecture. Osteoarthritis results from degenerative loss of articular cartilage. Rheumatoid arthritis results from autoimmune inflammation of the synovium with pannus formation. Ankylosing spondylitis involves inflammation of the spine leading to bamboo spine formation. Psoriatic arthritis often involves distal interphalangeal joints and nail changes. Reactive arthritis occurs after infection and typically affects lower limb joints. Understanding patterns of joint involvement and associated clinical features is the fastest way to answer arthritis questions in any exams. So, in the next video, we'll be getting back with another new topic. So, before doing that, I would like to request all of you to subscribe and keep supporting. Thank you.